Welcome, one and all. My name is Anna Lomprier, and I am a wayfinder. I work for the Cornwall Memory Cafe Network, supporting carers and people living with dementia to access services, make referrals, and really help them find a way to get more support. This is part of Disability Cornwall, and we've decided to create this podcast interviewing experts and people with lived experience on dementia to be able to share all sorts of interesting and informative and supportive information. So sit back and enjoy, and also share the podcast with your friends. It's relaxed and inclusive and welcoming, and thank you for listening. Welcome everybody to our Dementia Toolkit video series, a one-stop shop answering all your questions on everything dementia related. Simple educational advice from people with lived experience and professionals in their field. We aim to provide support that's personalised to help you on your dementia journey. Welcome everybody. Thank you so much for being here. We can all learn different information about this dementia pathway, whether you're somebody living with dementia, whether you're a professional in a different area, or whether you are a carer of somebody living with dementia. Today we have Allison O'Kelly, who is an advanced clinical practitioner, and she works within the memory assessment service. So thank you, Alison, so much for being here and giving us your precious time. Can you first of all tell us a little bit about how you've got into this in your career and what it is, what the memory assessment service is in Cornwall?
Okay, thanks for asking me, Anna. Back in 2005, we received funding to start a pilot of a memory clinic service, memory assessment service, for a year. So I was interviewed for that post and I was successful. When the funding ran out, the trust decided that actually we do need this, and the funding remained. And then in 2009, it was cascaded across the county so that we have actually got 8 teams of memory assessment clinicians. When I say teams, it's not a very big team. It will be a consultant, and it will be either a nurse or an OT, or we use also physician associates and assistant psychologists. That's right. I get my A's and P's and P's and A's muddled up. So yeah, we do get, when we started, we had maybe 3-4 referrals a week in my area. And now we get so many, we really do. And the staffing hasn't changed to be able to cope with that. So in some areas there is a waiting list, unfortunately, but we are working on it.
Okay, so you have grown this memory assessment service to be across Cornwall.
Yeah.
Can I ask then now, who is doing the referrals? Because this Dementia Together, there's this recognition that we are wanting to support people now to go on this dementia pathway, get assessed, make sure they're getting the care and the support that they need. So who would be doing most of those referrals?
They mostly come from the GP. Okay. But we are an open referral service, so anybody can refer to us. We do have some criteria. If you're under 55, we're probably not the right people. We don't have the expertise and the biomarker tests for people under 55s.
Right.
If somebody does refer themselves, or they refer a partner or a relative, we do need them to consent to the referral. And we do need the GP to do those initial physical checks and blood tests just in case there's a reversible cause.
Okay.
So most people go to their GP and say, my memory's not so good. And those checks are done then, and then they get referred to us. We tend to see people that have just started to realise that their memory's not so good. So it's people that there's no crisis involved, there's no risk. And do you want me to describe what happens after the GP refers them?
Yeah, that would be great.
Okay, so in where I'm working at the moment, and this will be hopefully generalised over the county, we have a weekly MDT, multidisciplinary team meeting with a consultant. Yeah. We look to see if the person already has a CT head scan, which we can use. If they don't, we'll refer them for one if we think that's necessary, and send them a letter to say that's what we've done. Generally, people get a routine clinic appointment, which means they'll meet either myself or one of the MAD clinicians in a clinic, or if they don't have transport, we do home visits. We do the initial assessment, we take all the information, and I think the most very important information is from their relative partner, that informant, because it gives us a lot of things that the person with the memory problem may not realise they're doing, like repeating themselves, that sort of thing.
Yeah.
So we take all that information back to our next MDT and discuss with the consultant, and then we make a decision at that point whether it'll be one of the memory assessment clinicians or the consultant that will see them for a further appointment for diagnosis, or whether they need a scan. If they need a scan, that again comes back to our MDT. We discuss it and then formulate a diagnosis from then, and it might be one of the clinicians or the consultant that gives that diagnosis. Possibly there is medication that we could prescribe, certainly for Alzheimer's disease. And it used to be as a trial because it was horrendously expensive, but now it's not. So we tend to prescribe it, or the GP, or we'll ask the GP to prescribe it for the first 3 months, see how it goes. If it has benefit, continue. If it doesn't have benefit, it's no point having another toxin in your body, really.
Yeah.
So that's what happens. That's where our pathway ends. But then we have the primary care dementia practitioners, and we discharge to their review case list, and they maintain contact with the person who's living with dementia and their carer's partner. And that's our service with the PCDPs is from diagnosis to end of life.
Okay.
So it is, we do work together really well, I think. We've got a new manager in the PCDP world. I don't know if that would be of interest to you to interview her as well.
Yes.
She's got a lot of progressive ideas. So I
What's
can give
her
you
name?
Finola Harrison.
Okay. Lovely, thank you. So then just to ask you, Alison, we're just going to imagine a person, they've been referred by their doctor to come for a memory assessment. And you're saying that the first stage is that you're going to be asking that doctor, have they had any brain scans? Is there any information that you can give us? Then you will have a meeting with the rest of your professionals, the consultants, and decide the best course of action, whether that's to have a brain scan, to have a memory test, all of that. And then overall with that person, would you, is that a process that takes, how long would you say, a few months?
If somebody's already got a scan within the last year, we can, it probably wasn't reported for memory changes, we can ask it to be reported for memory changes, or we can see it ourselves. GP doesn't have to provide us with scan pictures, because we can use the Derriford system. We can use the Trillis system. We've got access to that. If they are discussed at MDT at the point of referral, they could have a diagnosis by the time they get assessed, if that fits the clinical picture. If it doesn't, if we do see younger people under 65, or between 55 and 65, a lot trickier, because there's several things that mimic a dementia, like depression, anxiety, drug use, alcohol, that sort of thing. Or a typical presentation, which is normally another variation of Alzheimer's disease. So it could be posterior cortical atrophy, when somebody's spatial awareness is not so good. Their memory might be okay. Or we've got the frontal temporal dementias, where personality changes and behaviours is normally the first thing that changes, rather than memory. That can take a lot longer, but we do have access to OTs, occupational therapists. And we have got a psychologist who does neuropsychology tests, which is very, very useful. Again, that might be somebody that you might want to interview, because they do they do tests that are, I say, far superior to what we do, but of great value in people under 65, teasing out what is going on,
Yes.
But we have we have different types of scans as well. We have PET scans, which can determine if there's a dementing process going on. We have SPECT scans, which looks at the glucose use in the brain, and we often use that for diagnosing Lewy body dementia.
Got you.
No, sorry, that's DAT scans for Lewy body. SPECT scans is something we don't actually use that very often now, but yeah. So it's DAT and PET, that the other scans that we use. But it's mostly CT. CT is so good now. We don't need anything more than that usually.
Wow. And so with an occupational health person, then how do they support?
Occupational therapists?
Yeah.
Well, they've got some very clever tests. I didn't realize until I invited them to one of our forums, and they went through this array of quite interesting tests, actually, and very useful for people that have got sort of sensory deprivations, like can't hear, or that their speech is not so good, so they wouldn't score very well on my test. Yeah, they've got all sorts of different things, and it was actually fascinating to see what they actually do.
And this is all to diagnose, really, to find out exactly, to help that diagnosis.
If you think of it as a jigsaw puzzle, all in pieces, and then we have to put that together. We rule out things. That's how we diagnose a dementia. And the occupational therapists are very good at, if somebody scores very highly on my test, but they can't tell the time from their watch, then I would ask the OT to see them, because they're not functioning at the level that they should be. Or they score very low, but they're still, using a computer, shopping online, all those things. Then we'd have an opinion from an occupational therapist about, what is going on.
Yeah.
So it's all very useful.
Yes, I love that image of a jigsaw puzzle, and using different experts coming at it from different perspectives and you're saying you're discounting things. So you're by a process of, no, it's not that, you come to what it is. Another question then, we're nearly there now, is how do the PCDPs get involved then? So this person has had as they get their diagnosis under your analysis. You've
Yeah.
find that they've gone through this whole process and been given their diagnosis. Do
Yeah.
you then let the PCDP know? I suppose you let the doctor know, and that cascades a chain of care.
Well, they're employed by our trust, the PCDPs. They work in primary care. What we generally do is when we do a diagnosis letter, we copy it to them, and then we'll discharge from our caseload and we'll open it to that person. I did a joint not assessment, but a joint sort of interview with one of the PCDPs with a gentleman last week, because he'd already got a diagnosis. He'd been diagnosed elsewhere,
Okay.
but he hadn't had the post-diagnostic appointment that we offer to make sure they've got all the information, make sure they understand their diagnosis, and make sure that they, they're aware of support services, etc. So
That's so important. Can
yes,
you
it
tell
is.
me what that is? That's called a post-diagnostic.
Post-diagnostic is counselling, post-diagnostic counselling, and often we do that at the time that we actually give a diagnosis, because it's about explaining, making sense of what we're saying, and part of going back to diagnosis, part of the diagnosis can be, if it's in the clinic, we can show people their brain scans and show them what we're talking about, which I think is very valuable.
Yeah, I mean, that just sounds like an incredible level of care and service. Yeah, just to be not only to clearly understand and have as many questions as are
Yeah,
needed,
yeah,
and also to understand all the sorts of support
yeah,
that is out there and
yeah,
pathways that they can take.
yeah, yeah,
And to know that they're not just going to be left, they're going to have a PCDP follow up
yeah,
and be
yeah,
their
yeah,
person.
yeah.
It's incredible.
Well, I think it worked really well having the PCDP in the clinic with me, because they met her there and then. She had a chat with them afterwards, a supportive, reassuring chat, because people that get diagnosed elsewhere, they don't get our service, which is, and they don't get our information either, which is really important that people have that post-diagnostic service. So I would like in the future to work more like that, to have the PCDP in my clinic when I'm actually diagnosing somebody or prescribing for them. And we can do that handover there and then. That would be really, really good.
Yeah, that really would, wouldn't it? What a great vision that would be to action that. All right, Alison, well, we're coming to the end and I'm so grateful for your time. Is there anything else that we've missed, that if somebody is listening that is a carer
Yeah,
of a loved one or a
yeah,
cared for person, is
yeah,
there anything else that you would share with them? Any advice or anything we've
yeah.
missed?
Yeah, we do give out the Alzheimer's Society booklet for carers. There is the Admiral Nurse Service that we can refer them to. Again, you might want to interview somebody from their service.
Yeah, we have.
Okay, so that would be Caroline, probably.
Yeah.
She was one of my MAS clinicians back in the day.
Wow.
Yeah.
Wow.
Yeah, so we have that, and on our letters we have emergency contact numbers and also the community gateway as well, so that people can, they're not just left with
No.
nothing. The PCDPs now have dementia advisors as well, so
Yes.
they can be discharged, the dementia advisors, because they don't need to be in secondary care, if you know what I mean. They are living well with their diagnosis. they don't need anything at that moment in time.
Yes.
So they look after them. Dementia advisors are brilliant because they are a fund of knowledge that I don't have about what's going on in the local areas. And I just need to concentrate on,
Yes,
what I do.
absolutely. Your
And
area of
others,
specialism.
yeah, others can do the other bits, do the support work and
Absolutely.
everything. Yeah.
And those dementia advisors, they're with Disability Cornwall, they
Yeah.
are with Memory Matters
Yeah.
and the Alzheimer's Society,
Yes.
I believe.
Yes. Yeah.
So they're covered across the whole of the
Yeah.
county, aren't they?
Yeah, it's great. It's brilliant.
So things are really looking up. And
Yeah, I think so.
yeah. So, and how do you think, so what do you think the average wait time is? This is the last question.
Okay.
For someone that is being referred from their GP, what do you said you had a waiting list. What do you think that wait would be?
That varies across county. In the east, we don't have a waiting list. We don't, not in the North Cornwall either. So that's sort of that Derriford facing and Barnstable facing areas. They don't have. We don't have a waiting list. In the middle of Cornwall, there is a waiting list. I know that at one time it was a few months, and I don't think it's too bad. The west of Cornwall, so it's really difficult to say. But these are people that have got the first signs of mild memory problems. That's who we should be seeing. So anybody that is sort of like bedbound, the whole family think they've got dementia, or if they're in a care home, we call them the Memory Assessment Service GPs that will go and see these people and do a brief memory test and decide on a diagnosis. A diagnosis it opens doors for people. As I've said, all those support services, people in care homes don't actually need that because they're being looked after, they're being cared for. But it's really important that the GP knows that they have a dementia and the care home knows that they have a dementia, so they can adjust accordingly to that person's needs.
And like you say, that diagnosis is a key to a lot of support from your primary dementia care practitioner. It's like a sort of ticket to people understanding that you're living with a disability. There's lots of benefits. It's adult social care will take it more seriously if you're living with a disability. The Admiral nurses, all these different services step in then, don't they?
Yeah, that's right.
Amazing. Well, thank you so much. And if people did want to self-refer, then how do they find you? How do they find the memory assessment clinic service?
I suppose that's a bit of a tricky one. If somebody doesn't use a computer or a tablet, if they do, they can go onto the CFT website, and the phone numbers for all the different clinics are on there. Otherwise, they can phone our switchboard. Let's see if I can find the number for you. Okay, so it's 01208 251 300. And
Thank you, Alison.
They just need to say which area they're in and the GP practice, and they should be able to find the right clinic service for them.
Amazing. Thank you for all the work that you do. Really, really such a pleasure to talk to you.
Thank you, Anna.
This video was produced by Discover Voices, part of Disability Cornwall and Isles of Scilly. To check out all of our content, simply search Discover Voices on YouTube.